Diagnexia Case 3. This is a case of a 37-year-old female who presented with a solitary thyroid nodule, which was removed by a left thyroid lobectomy. An FNA procedure was performed and the diagnosis of papillary thyroid cancer was rendered preoperatively. The lobectomy specimen contained a single, well-circumscribed, encapsulated 2.5 centimeter in maximal diameter yellow-brown nodule. And here is a low magnification of the specimen with the well-circumscribed nodule clearly apparent. It is indeed encapsulated with a well-defined fibrous capsule with retraction artifact from the adjacent thyroid parenchyma. And even at this magnification, one can discern that there is compression of the thyroid tissue immediately subjacent to the nodule, whilst the thyroid parenchyma further away shows areas of chronic lymphocytic thyroiditis, as evidenced by these sort of bluish appearing areas. Under closer magnification, again, the adjacent thyroid parenchyma has chronic lymphocytic thyroiditis, but otherwise appears somewhat unremarkable. The well-defined capsule of the lesion, and you can see it is a relatively cellular lesion with areas of stromal fibrosis and hyalinization. At this magnification, spicules or shards of bone can also be discerned within the stromal component. Again, you can see that the cellular component is organized into nests of varying size, and here is the stroma in which the cells are embedded, clearly hyalinized, in some areas more paucicellular than others. A higher magnification, again showing the thick fibrous capsule with some of the capsular extension into the lesion, showing osseous metaplasia. You can see that the nests of cells are organized and surrounded by thin capillary network. Under closer magnification, the cells are oval to polygonal in shape, with a relatively uniform population of cells showing mild nuclear pleomorphism. The nuclei vary from being round to being slightly more elongated, and indeed some of them bear longitudinal nuclear grooves. The stroma here as well can be seen to be hyalinized and punctuated by thin-walled vessels. Also present are clear nuclear pseudoinclusions as well as eosinophilic ones, and not very well demonstrated in this particular case, but certainly a feature worth looking for are the cytoplasmic aggregates of pinkish yellowish material, which sometimes can be large enough to impinge on the nucleus, denting its nuclear contour. A multitude of immunohistochemical stains were performed, but the one of relevance and of diagnostic importance in this particular case is the Ki67. And as you can see, there is membrane and cytoplasmic decoration of the tumor cells, in contrast to the usual nuclear positivity associated with Ki67. This lesion, together with sclerosing pneumocytoma, gives rise to this characteristic membrane and cytoplasmic staining with Ki67, which is clone dependent. The diagnosis in this particular case is a hyalinizing trabecular tumor of the thyroid. The entity was first described in 1987 by Aidan Carney from the Mayo Clinic, and he gave it the name of a hyalinizing trabecular adenoma. Shortly thereafter, others described it as a paraganglioma-like adenoma of the thyroid, in view of its close resemblance to a paraganglioma in that it is nested. So the gross and microscopic features, over and above the ones that I have just mentioned, it is always well circumscribed and indeed encapsulated, a very consistent gross finding. In addition, and not demonstrated in this particular case, one may encounter psammoma bodies. Additionally, the cytoplasm contains these yellow spherical paranuclear cytoplasmic inclusions, which I try to illustrate, that are 2 to 5 microns in diameter and sometimes can be surrounded by a clear halo of retracted cytoplasm. And if they're large enough, they can impinge, as I said, on the nucleus, creating nuclear molding or indentation of the nuclear envelope. And these cytoplasmic eosinophilic globules are basically giant lysozymes and are thought to be present in every single case of a hyalinizing trabecular tumor. It is a unique neoplasm derived from follicular epithelium, and it happens to demonstrate a very prominent trabecular architecture. The trabecular architecture can sometimes be focal, and the majority of the tumor is made up of a nested pattern. And similarly, the characteristic stromal hyalinization can vary in its amount, and it can be present to a large extent in some lesions, whilst minimally seen in others, as demonstrated in this particular case. Given the cytomorphology that I've described, there is, of course, considerable microscopic overlap with papillary thyroid carcinoma, something to bear in mind as we move along. It occurs in young females, and similar to papillary thyroid carcinoma, it has a similar age and gender predilection. Hyalinizing trabecular tumors have been seen in association with chronic lymphocytic thyroiditis in multinodular goiters, patients who've had radiation exposure, and indeed can occur in conjunction with classic papillary thyroid cancer. Now, whether chronic lymphocytic thyroiditis is a meaningful association is somewhat conjectural, given that chronic lymphocytic thyroiditis in its own right can be quite commonly encountered. However, more than 60% of cases that have been described in the literature of hyalinizing trabecular tumors do have associated chronic lymphocytic thyroiditis in the background thyroid. Includes medullary carcinoma in view of the nested pattern and the stromal hyalinization, which can mimic amyloid. Clearly, immunohistochemistry, family history, especially in young patients of MEN, are useful in separating medullary carcinoma from hyalinizing trabecular adenoma. Similarly, a paraganglioma has a nested pattern and is invested by a delicate vascular network, as seen in the more cellular areas of this particular case, and indeed primary thyroid paragangliomas are well described. Again, immunohistochemistry with S100 delineating the sustentacular cells around the nest of cells is an important feature to help distinguish. Then, of course, the most difficult diagnosis to separate is a papillary thyroid carcinoma, especially those with a trabecular architecture, and we'll try and separate these later on. Another light microscopic consideration is a follicular adenoma with a hyalinizing-like pattern. However, follicular adenomas do not have the nuclear grooves, the pseudo-inclusions in the nucleus, and some bodies. Immunohistochemistry of hyalinizing trabecular adenoma being of follicular derivation, it is TTF1 and thyroglobulin positive. Other markers that are used in the papillary thyroid cancer dilemma, HbME1 shows variable expression, as does galectin-3, but several tumors, hyalinizing trabecular tumors, have been noted to show expression of these two antibodies. Classically, the Ki67 or MIB1 membranous staining pattern is of diagnostic importance in separating papillary thyroid cancer from hyalinizing trabecular adenoma. The vast majority of hyalinizing trabecular adenomas are CK19 negative. There are one or two studies that have shown positivity of CK19, but the vast preponderance of studies show CK19 to be negative. And of course, S100 and calcitonin are negative in excluding paraganglioma and medullary carcinoma of the thyroid. Interestingly, molecular evidence shows that hyalinizing trabecular adenoma is indeed a distinct lesion from papillary thyroid cancer, because GLIS1 and GLIS3 fusions with Pax8 are seen in almost 100% of hyalinizing trabecular tumors of the thyroid, and this is of key diagnostic importance. About 20 to 60% of hyalinizing trabecular tumors can show RET and PTC rearrangements, which are also seen in papillary thyroid cancers. And since these were the early molecular aberrations seen in thyroid neoplasia of papillary thyroid cancers, and given that both PTC and HTT showed similar rearrangements, it was therefore thought that hyalinizing trabecular tumor was part of the spectrum of lesions encountered in papillary thyroid cancer, and therefore was a variant or perhaps along part of the spectrum of changes. Interestingly, BRAF and NRAS mutations are not found in hyalinizing trabecular tumors. In terms of behavior, it is an extremely low-grade lesion or low malignant potential lesion, invariably benign. However, cases with capsular and vascular invasion have been documented, and one wonders whether this is in fact a variant of papillary thyroid cancer rather than a hyalinizing trabecular cancer. However, if the molecular features fit and the lesion shows capsular vascular invasion together with GLIS1 and 3 fusions with Pax8, then it is this rare example of a hyalinizing trabecular carcinoma. Something to bear in mind at this stage is that the optimal treatment for a hyalinizing trabecular tumor is a lobectomy rather than a thyroidectomy. So the distinction between hyalinizing trabecular tumor and papillary thyroid cancer clearly has got operative consequences. The follow-up recommended after lobectomy is to look and see what happens to these particular patients with hyalinizing trabecular tumor. And finally, just to help with the separation of hyalinizing trabecular tumor from papillary thyroid cancer, especially the trabecular patterned variety, points of similarity and dissimilarity highlighted in this particular table. Both occur in young females. Both can show nuclear grooves, pseudo-inclusions, and psammoma bodies. Clearly, papillary thyroid cancer tends to have more of these features. Hyalinizing trabecular tumor and PTC share TTF1 thyroglobulin, HbME1, and galactin-3 positivity. However, only papillary thyroid cancer tends to be positive for CK19, with 60 to almost 100% of cases showing positivity. This curious Ki67 decoration of the membrane and cytoplasm occurs in hyalinizing trabecular tumor rather than in PTC, where Ki67 labels the nuclei. And of course, the GLIS1-3 fusions with Pax8, which is found in 100% of hyalinizing trabecular tumors, thus delineating it as its own entity, is not seen in PTC. BRAF mutations, furthermore, are not found in HTT, nor are NRAS mutations. In contrast, BRAF is found in 60% of papillary thyroid cancers, whilst NRAS mutations are seen in 15% of papillary thyroid cancers.